let me introduce the next speaker. Is Dr. Justin Davis. He's a senior research fellow and honorary consultant in the Imperial College of London. He has a lot of research area. Out of that, his main research area is validating the IFR technique for coronary physiology. And without further ado, I'll start the lecture from Dr. Justin Davis.
I'm Justin Davis, interventional cardiologist from London, and it's my pleasure to be here with you at your meeting in Sri Lanka to discuss coronary physiology, a topic which I love. Very grateful for the invitation, and hopefully in the next 20 minutes I'm going to walk through some contemporary ways of assessing lesions, both in using the vessel level ischemic methods and also looking at lesion level assessment as well. So this is a great slide from Dr. Nam in South Korea, and it's for a whole series of publication he presented, essentially looking at how the circumflex artery ostium can be give the appearance from an angiogram of being pinched after PCI to the LED left main stem. And the study he did was to essentially look at each of these branches using FFR, and then repeated the measurement after a few months to see if the FFR had changed and if the vessel still remained intact and patent. We'll come back and revisit this later on, but just remember this image and think what you would do in this case. Would you leave it alone? Would you measure physiology, or would you balloon it or stent it even? Here's another case, and we're going to discuss this case as well. So this is a patient with stable angina, some evidence of chest pain on a myocardial perfusion imaging scan, and a tight lesion in the mid-circumflex artery, and a more hazy lesion in the proximal LAD. How do you treat this patient? You know that these lesions in the circumflex from physiology can often be disregarded, as the territory is often small, and often the proximal LAD can be surprisingly more positive than you may think. But what would you do? Would you just go ahead and treat? Or would you use physiology or some other methodology? I'm going to show you this case again later as well. Have a look at this. Is this a good candidate for PCI? Looks like a great type A lesion, nice one to stent. I'm sure we all think would make a big difference here. Similarly, in this patient here, another lesion which would be pretty easy to treat, and I think we'd do a good job here as well. Well, I want you just to consider this more widely. Of course, these patients are all from the Orbiter study, a study which we ran from our hospital in London here. And as you know, this study didn't confirm that PCI conferred an advantage over placebo in terms of improvement of exercise capacity. There wasn't marginal improvement in exercise capacity to patients who received stenting, but not over and above placebo. And I'll just remind you, if you're less familiar with the protocol, that this used the angiogram to guide which patients had treatment, and it didn't use coronary physiology. Now, the other bits of information we have with regards to the efficacy of stenting when you use the angiogram alone, of course, this field was opened up really by the COURAGE study, which compared using PCI to medical therapy. And then they were unable to show really a big significant benefit of using PCI over and above medical therapy, which I think even up to 7 years surprised many people. So I think we need to question, why do we revascularize coronary stenosis? Some people do it because they like the technicalities of it. Some people they want to make the artery restored back to what it was like when the patient was first born. But really, why do we do it? We do it to increase coronary blood flow, to reduce ischemia, and to make sure that our patients have less symptoms of angina, can go about their lives in a more normal way without getting breathless or symptoms of chest pain. So this is very important to always remember. Grunzig, pioneer of balloon angioplasty and stenting angioplasty, was very much in favor early on of using physiology, whether that's initially started out to be pressure measurements with these large catheters, and then it's evolving over time to Doppler catheters, and then over to Doppler and pressure wires, and then combined Doppler and pressure wires. These tools provide some objective measure of the efficacy of PCI, and as we found out, the ability to predict the patients who are more likely to do better from implantation of stents or deferral. And this whole field was opened up and really pioneered by the introduction of the pressure wire. Nico Pils, Bernard de Bruyn led these studies, the first study, a small study by today's day studies. But you can clearly see at a time when everyone was thinking that we should be stenting everything, we should be opening up all arteries to make them look angiographically normal, they demonstrated that you could safely defer people who had an FFR more than 0.75, and even up to, the initial study was 5 years, but up to 15 years, these patients did very well. So this was a very important observation, and it showed us for the first time that maybe PCI wasn't amenable to everyone. Then, of course, other studies came out, FAME 2, as you're familiar with, and probably the most important of these was the FAME study, which showed us that you could get an improvement in a survival-free from MACE by using an FFR-guided strategy when compared to an angiographic-guided strategy. And that was, of course, the first time it showed us that we could use physiology not just in terms of deferring patients, but also in a way of helping to guide therapy and who should be treated, who shouldn't be treated. So very important pivotal studies. And of course, the whole backbone of all of this is that the angiogram itself is not very good at telling us all the information we need to know to make informed decisions about PCI. So this is a nice slide here from Nick Curzon, and you can see here at the bottom he's grouped these lesions according to their angiographic stenosis severity, so 0 to 30, going all the way up to more than 70% on the far right side of your screen. Now, as you'd expect in patients who had a near no angiographic stenosis, most of the FFRs are above 0.8. But it always intrigued me that you get some cases where you have very, very significant FFR values. And of course, this could be a mistake in the measurement. It could be, these are a case where there's a massive Venturi effect. So you have a high flow giving a false positive FFR. But as we found out, and I'll touch on this later in the defined PCI study, there are many cases where we just miss treating the most severe lesion. And it's very interesting that perhaps the angiographic view that someone was looking at wasn't the one which captured the lesion, or perhaps there was a whole series of diffuse disease which all added up to being much more significant than the operator thought. So this mismatch between angiographic appearance and physiology is really, really important, especially if we know that physiology confers improvement in outcomes. Now, despite physiology with FFR giving us the RCT data that needed to get clinical trial evidence and guideline a 1A classification, we know that the adoption until recently remained really low. And around 10 years ago, we introduced the IFR technique. It was first presented at TCT with the ADVISE study. And really, subsequently, you've seen that many of the leaders around the world, including Mort Kern, essentially was saying that FFR was a good technique, but it wasn't used as often as it should be because of the barriers to entry. And he lists adenosine and talks about it being difficult to mix, costly, time-consuming, and potentially dangerous for patients. And of course, it's usually uncomfortable for patients. So IFR moved us away from this adenosine-based measurement to a resting measurement, where measurements are made over a phase of the cardiac cycle called the wave-free period, where there's resistance is naturally lowest and most stable, and gives us the opportunity to make these measurements more precisely. We ran a large study, 2,500 patients, called Defined Flare, one-to-one randomizing patients to either getting FFR-guided therapy or IFR-guided revascularization decision-making. There's a great blinding this study, so the patient didn't know which arm they were in, nor did the follow-up team as well. And we classified the MACE, so the major adverse cardiac events, and reported these at 30-day, 1 year, 2 years, and we'll report 5-year data soon as well. And MACE was a combination of death, non-fatal myocardial infarction, and unplanned revascularization. Similarly, at the same time, Matthias Bergwall of Freiburg in Scandinavia, as part of the Sweetheart Registry, running IFR Sweetheart study, very similar study design, but 2,000 patients, one-to-one randomization. The key difference here, this was a randomized registry as opposed to a randomized trial. But the beautiful thing here, because we designed these two studies together, is the definitions were identical, as was the MACE. So it enabled us to look at both of these studies individually, but also to combine them together to give us more power. Just to give you an insight, the cut point for FFR is 0.80. The cut point for IFR is 0.89. And we use these in both of these studies, as had been used before in the FAME and FAME 2 studies. The IFR sweetheart study was, as I said, mainly performed in Scandinavia. The DEFINE FLARE was a global study with recruitment in 49 centres and 19 countries from around the world. The physiology in the DEFINE FLARE and IFR sweetheart study was very typical to what we see every day in the cath labs around the world. So these are patients with an IFR of 0.83, an FFR of 0.83, and you see this is very, very different from the other clinical trial data that we had out there from DEFER, which was very, very significant. We don't often see FFR values that low, and FAME2 also very low as well. But this was very representative of what we see day in, day out in the cath lab. We also have, of course, more contemporary data, the Syntex-2 trial, which I'll cover later, which is in more complex patients, which tend to have more significant physiology values as well. One of the main findings of both the DEFINE FLARE and IFR sweetheart study, this was combined data here, it shows us that we defer slightly more patients using IFR than FFR, which means that there's slightly less PCI and slightly less CABG in the IFR group. Now, that could be a good thing, it could be a bad thing, and it really depends on the findings from the Kaplan-Meier curves, which look at MACE. And you can see here, this is the 1-year data, shows us a hazard ratio of 1.03, which confirms that if you use IFR or FFR, the results are identical when guiding revascularization decision-making. What we do know, and I'm sure you know this from your own practice, is if you give adenosine, you're going to get symptoms. If you don't, you'll get fewer symptoms. And of course, we found this in the both studies, just about a 90% reduction in symptoms. And overall, because it spared the time for mixing adenosine, administering adenosine, so on and so forth, it was a 10% reduction in time. Both studies, the 1-year data for IFR sweetheart and DEFINE FLARE, were published in the New England Journal of Medicine. Subsequently, both FFR and IFR have got 1A classification in the European Society of Cardiology guidelines, and similarly in Japan as well, and also guideline representation now in the United States as well. Manesh Patel presented at the ACC on data showing the cost effectiveness of IFR. Remember, FFR has already proven to be cost effective over angiography, and now we're showing that it's possible to reduce cost by around $900 when compared to an FFR guided approach that's using IFR. We have great data which has come out looking at the endpoints. This is data here from the IFR sweetheart data sets at 5 years now. And you can see here, this continues to show equivalence between either an IFR or an FFR guided approach, both in terms of the Kaplan-Meier curves, but also if you look at each of the secondary endpoints as well. DEFINE FLARE is a little bit behind in reporting the results. We've got the 2-year data, which came out a year or so ago, and this shows us, again, equivalence between IFR and FFR, and next year we should report the 5-year data from DEFINE FLARE as well. So really, without question, we know that these studies, IFR sweetheart and DEFINE FLARE, show us that there's equivalence between using either an FFR or an IFR-guided approach to guide revascularization. We've found a beautiful further assessment made by lumping together all this data at 2 years, and Javier Escanad, a close friend and colleague from Madrid, put this data together. So this is a huge number of patients, 4,500 patients almost here, and showed us whether you use an IFR or FFR guided approach, the outcomes are identical. But very interestingly, and I'd always like to mention this point, that really often a lot of the benefit from physiology comes from choosing the patients who we can defer treatment on. And you can convincingly see here that, yet again, IFR and FFR, the MACE rate is pretty much identical here, albeit with more patients deferred using IFR than FFR. So it shows us that there are probably going to be some patients we're treating with FFR that is unnecessary, and when we defer them, we get an event rate which is lower from deferral than in the treatment group. So this is a very, very important observation from these studies, and it's also very, very important for us to respect. And in some cases, it's beneficial to patients when the physiology is negative to defer them as opposed to offering them PCI treatment. Now, all of these studies really have been looking at vessel level of ischemia. That means positioning the wire down to the end of the vessel and looking at the entirety of the artery. Now, that's good, and it's certainly better than looking at the angiogram alone, but what we're starting to understand is there's different patterns of disease in the vessel. This is an IFR pullback here. So this is a technique called IFR Scout, which essentially can be used by slowly withdrawing the pressure wire down the length of the vessel. And here you can see there's no big step-ups on the first curve on the left-hand screen. And this is called diffuse disease, diffuse atheroma. There's no step-ups, which would be nice landing zones for a stent. And it's likely if we were to stent large amounts of the artery here, you're going to have a small increase in blood flow. On the other side of the screen, you see these big step-ups, and they really are very big step-ups here. And this is often where you see atheroma, clear landing zones, and likely if you treat this patient, there's going to be a big increase in blood flow. One of the big advances recently in coronary physiology has been the fusion together of the angiogram with the physiology data using the IFR, and this is the sync vision system. Here you see each unit of IFR represented as a yellow dot, and when you see lots of clustering of yellow dots, like in the proximal portion of this LAD, you see that this is likely to represent a high area of focal energy loss. Each dot, as I said, represents a unit of IFR, and you can see the computer has added these dots up for us in the screen here and said there's 25 units. This is over a 15 millimeter segment. We know this because everything is calibrated in these systems. And what that means is if we were to do perfect angioplasty and relieve all of this energy loss here, we would increase the distal IFR from 0.6 to 0.85. So it helps us predict future PCI ahead of actually opening up a balloon or stent. Now, this is important. Here's two different patients. One's from Syntex 2, one's not. But one of these patients received a short 8 millimeter stent and improved their physiology to almost 1 from being very significantly abnormal. And the other required the whole artery to be stented. And usually when I ask people which was which, it's basically 50-50. It's a guess. People are uncertain which one it is. And that's because from the angiogram, it's very difficult to know what's really going on. So physiology is often thought of as being very simple red-green traffic lights. But as what I've shown you, I think that we need to interpret things in more detail. We need to be using these pullbacks more often, and they're going to give us added information. You can see on this illustration here, on the pullback, you can see the first case I showed you, you saw a little clustering of dots in the proximal portion of the LAD. Now we can see diffuse disease over the proximal and mid portion of the LAD, but another clustering around the mid portion of the vessel. We're going to go on here and we're going to go and see a case example, which I'll show you. And this is the case which I showed you to start off with. So stable angina, positive myocardial perfusion imaging, tight lesion in the circ, and a hazy lesion in the LAD. What would you do? Well, I can show you what Javier did. This is part of one of our courses that we run from London. You're very welcome to come and attend that course. First off, use an EBU 3.5 guiding catheter. Gave 200 to 300 micrograms of nitrates. It was well opacified, put the pressure wire down the circumflex artery, and then, we clearly saw there was a lot of ischemia in this vessel. So circumflex can often be, very, very negative, even when angiographically it looks tight. But in this case, it was very, very positive. Now, we saw and identified on the angiogram that lesion in the mid-vessel. So what we're going to do now is do a slow pressure wire pullback. This is how we do the co-registration. So we're screening all the time as we come back. And what we're looking to see is where this step-up was. Now, many of you will be thinking that the step-up should have occurred already, but you can see the blue line is absolutely flat. And we're pulling back further and further and further and further till eventually there's a big step-up which occurs in this artery. So at this moment in time, we didn't know what was going on. We thought, had the system got it wrong? Was there a problem? Had it misinterpreted the pressure step-up? And, we started to think, well, maybe it's the fact that, the angiogram had deceived us, and what we thought was the tightest angiographic area actually wasn't. And this is a real life illustration during a live, case during a course, physiology course, where we actually were looking at this. So, we finished the pullback. The next thing you have to do is fuse this together with the angiogram. It takes, a few seconds to do. You pull up the angiogram, and we just make sure that the map has been produced correctly so that the computer knows where the center line and the data essentially lies. Once that's been done, over the top of it, you're fusing together the angiogram. Here's the the fusion together, this center line generation. We're putting on the physiology data on top of the angiogram, and it really helps us to simplify things hugely. You know where the pressure loss is occurring. It's very simple, very quick, very easy. And you can see here, it wasn't where we thought it was. It was much higher up. And there was another lesion hidden in this mass of more proximal disease in the circumflex. And in actual fact, the area we thought was significant really wasn't that significant at all. So we mapped this out again using the Sync Vision system. Javier planned a balloon and stent strategy. You can see this is the lesion here now, which we thought was significant, isn't so bad. So physiology wasn't lying to us. He ballooned, stented, and then according to this physiology, the map beforehand, we anticipated that we'd get a very good result after stenting that proximal portion and wouldn't need to do any more. And indeed, that's exactly what we found. We've remeasured afterwards. You could stent more if you want to, but we found we didn't need to. We'd already moved it from 0.35, 0.36 to 0.94. Fantastic result for a patient. And indeed, the residual energy loss here was very, very small. So, visually identified target, functionally relevant lesion. Remember that. The physiology helps us identify really what's going on in the artery. And this lesion, after treatment, was very successfully treated. Proximal LAD was totally negative at 0.95, so we left that alone. Now, we're really starting to understand more about the importance of lesion level of ischemia. We run a study alongside Manish Patel and Alan Jeremiah's 500-patient pilot study called Define PCI. And this study essentially was looking to see how often do we leave patients at the end of the PCI procedure with a physiologically significant lesion still? And if they've got one, is it due to diffuse and focal disease? So this was the first study really to look at this. It was all blinded. So when the operator finished doing the PCI, they had to say, I finished. The screen was turned around. They made a measurement in a blinded when they did the pullback. And what we found out is that almost a quarter of patients had evidence of ongoing ischemia at the end of the case, which is surprising. I'm sure that surprises you. I think a quarter of your patients probably still has ongoing ischemia. And of those, around 80% had evidence of a focal lesion, which was still present. So there was some disease here or there, which potentially could be treated. And if you could treat it, potentially you could have a better outcome for your patients. So this was a pilot study. It was a pilot study into the Define GPS study. Define GPS is a fantastic study, which is just getting underway now, up to 3,000 patients enrolled. And essentially what it's doing is it's comparing using this Sync Vision system in one arm against using just conventional angiogram. Both arms have got people who've got physiologically significant lesions, but one we're using this advanced technology to pin down where the localize the lesions and actually prescribe the likely improvement that they can get from the number of dots. And the other essentially saying we're using old school treatment like they did in the FAME study. And we're looking to see if we can confer a big advantage to patients in this well-conducted RCT using this new technology. So very, very exciting. We think it's going to be very, very important for the future of PCI, and I think incorporating, the state-of-the-art physiology in addition to imaging is going to be very, very important to make sure we have good quality results for our patients. So just to summarize, IFR and FFR have similar outcomes at 2 years. Deferring using IFR or FFR is very safe, and in fact has a lower event rate than treatment. IFR and FFR is recommended in the US, European Society of Cardiology and Japanese guidelines. We know from data that IFR is more cost effective than FFR. We know that it takes a short amount of time. It's more patient friendly. And there's some other data which I haven't shared with you today that also shows that in acute coronary syndrome, it may give us a more reliable result. So when you're out there, just remember, the angiogram gives us some information, but the angiogram can also lie to you. These are all the patients in the Orbiter trial. And remember the results of that study, which were very similar to the Courage study. Neither showed us that PCI offered a big advantage over medical therapies we thought. Hopefully today I've shed some light into why that could be the case, and also given us the opportunity perhaps to treat our patients more carefully and with more precision using these techniques. Thank you very much.
Thank you. Thank you, Dr. Justin Davis, for that very thought-provoking lecture.